is going to make you a co-host so you can share your screen.
You're good to go.
Okay. It sounds like you're good to go and share your screen. While you're doing that, I was just going to put in a quick plug again for the 6th Cancer Cachexia Conference taking place in August, the 27th to 29th in Gainesville, Florida. There's a hybrid option as well if you can't join in person. So registration is open, so please visit cancercachexiasociety.org. I am really pleased to introduce Dr. Andrew Hendifar, joining us from Cedars-Sinai. He's a GI oncologist and specializes in pancreatic and neuroendocrine tumors and has done a lot of work in cancer cachexia. So with that, I'll let you take it away.
All right. Thank you, Rishi. Thanks for having me. Really delighted to be here this morning. I think we're outnumbered as far as medical oncology, huh? So I think I'm going to try to keep this so that it's really relevant to everybody on the meeting, on the Zoom meeting this morning or this afternoon, depending on where you are. If you have any questions or any issues, please immediately chime in because, I think Rishi also kind of like me does a lot of clinical research, and it might be very different from what a lot of people on this meeting are doing. So please just chime in if you have any questions or you want to ask something. So when I first started treating pancreatic cancer, I had never had a mentor who did cachexia research, and I kind of fell into this field just because of how thin and how much weight these patients are losing. So that's kind of my background and how I came into it. And I went from developing therapies for pancreas cancer to also developing therapies for pancreas cancer weight loss, kind of a natural evolution here. All right, let me try to advance. So with pancreatic cancer, it's a very difficult disease because the outcomes are so poor. The average 5-year survival is 10%, making it one of the worst outcomes out of any tumor. So right now, it's the 4th leading cause of cancer death in the United States, and about 60,000 cases a year. It's also both men and women, and the top 10 as far as incidence, non-discriminatory disease. And what's also really concerning is the outcomes are projected to continue to worsen, and it will soon become the 2nd leading cause of cancer mortality, followed only by lung cancer, which of course, because of tobacco use, has been a worldwide issue for a long time. Actually, lung cancer is getting much better now, right? There's recent data showing that the outcomes are improving because of immune therapy. Pancreas cancer, not the case, not the same. So cachexia, interestingly, is also an incredibly important part of pancreatic cancer. We looked at 2,000 patients from the Kaiser Permanente registry. Now, Kaiser Permanente has had EMR for electronic medical records for quite some time, and their patients are all taken care of within the same system. So you can get weight data that predates the diagnosis of pancreatic cancer. So we looked at about 2,000 patients who were diagnosed with pancreas cancer, and we had about 1,000 patients who we were able to see that they had weight measured 6 months prior to diagnosis. And we found that 2/3 of the patients had cachexia. Not only that it was independent of stage of presentation. So it's definitely an intrinsic part of the disease, and it definitely occurs in early stage. So, depending on which data set you look at, 85% of patients will present with weight loss at the time of diagnosis. And 80% will continue to develop weight loss even after diagnosis and optimal medical management. And it's been shown over and over again that weight loss and decreased lean body mass is associated with poor prognosis, increased toxicity, post-op infections, and decreased therapeutic intensity. Now, I think the etiology is a little bit unclear. There are some preclinical data that a lot of it is driven by altered exocrine function. But I think in the clinic, we kind of take a different perspective on the disease. So here is a kind of an organized way to approach weight loss in a patient with pancreatic cancer. And we like to divide it into three categories. One is anorexia. Patients will often have loss of appetite, nausea, pain. Pain is a huge issue. Some of it is tumoral related, and some of this nausea and loss of appetite is related to therapy. Another category is malabsorption. Many of these patients will develop exocrine pancreatic insufficiency, altered exocrine function, because the tumor itself is damaging the pancreas gland. Pancreas gland is unable to secrete pancreatic enzymes necessary, and this has to be supplemented. And finally, there's cachexia, of course. And this could be demonstrated in the clinic by patients who have reduced strength, reduced physical ability and performance, and associated fatigue. So we've also put together a number of assessments that can be done for patients. We can try to assess exocrine pancreatic insufficiency. We send them to dietitians. We can do tests looking at inflammation, testosterone, baseline A1C. I think in the clinic, we really try really hard to send everyone to see a dietitian, have a low bar for replacing pancreatic enzyme supplementation, have everyone who needs to see a physical therapist, and really kind of stay on top of the patient's weight and physical function during the treatment course, from diagnosis to first and second line therapy. Now, what's really interesting about this issue of cachexia and pancreas cancer is that I would say it's, in my opinion, and we have data to support it, but it's really limited to those patients with pancreatic ductal adenocarcinoma. If a patient has a pancreatic neuroendocrine tumor, they probably will not have, they do have weight loss, but not as often, definitely not at the prevalence rate as you find in PDAC. And we also noticed that patients with PDAC or the adenocarcinoma, the tumor itself will damage the gland, whereas in a neuroendocrine tumor, the gland kind of doesn't undergo the same issues. And besides that, all of the metabolomic changes that you would see in PDAC are not occurring in PNET. And you can see in table 1, this is a very old table, but it really hasn't changed. I think the main thing to notice is that for PDAC patients, KRAS alterations predominate, and all the downstream, metabolic derangement, the microenvironment, all very distinct from pancreatic neuroendocrine tumors, which have a completely different genomic profile and biology. And here, PDACs are symptomatic, whereas PNETs can be incidental. And again, we talked about damage to the gland. So here's from my clinic. You can see my awful handwriting. So here's an example. So we've been piloting, looking at using pancreatic elastase to kind of help us categorize patients as far as their exocrine pancreatic insufficiency. Not the best tool, but probably the only tool we have outside of our clinical exam and discussion with the patient about their symptoms regarding their stool and their weight and their malabsorption. Here you see a pancreatic neuroendocrine tumor that's locally advanced and a pancreatic elastase score quite good. And here's an advanced pancreas cancer patient who we checked the pancreatic elastase and less than 15. And we've published this. I mean, we've done a series of looking at pancreatic elastase in neuroendocrine tumor patients. We haven't found any of them that had a low elastase score. Interestingly, PNETs will have EPI, not from the tumor, but from the treatment. So somatostatin analog therapy, which is a standard treatment, will cause EPI, but that's a different issue. So I think what was really important for us to talk today, Rishi has been doing a great job on a randomized clinical trial in pancreatic cancer cachexia. And I thought it was a good opportunity to kind of just talk about this particular field a little bit, just to give some understanding of the things that trialists think about when developing trials for cachexia, And really just to get everybody involved and on the same page. I think when I was doing this, I kind of did it alone and I made a lot of mistakes. So I would encourage everybody, we definitely need to communicate a lot in this field, talk to each other, get each other's input, and come to some kind of consensus about how to do this the right way. So let's talk about some issues. If anyone wants to shoot a question in the chat, they can do that too. Okay, so issue number one with developing trials and this entity is that definition. So, defining cancer is really easy. Take it for granted how easy it is compared to defining cachexia, right? So cachexia is a complex syndrome, and typically in a clinical trial setting, you'll define it by weight loss because that's the most consistent, easiest proxy you can use. It's hard to use other criteria to define it. And the other thing that's hard about cachexia is that most fields are developed enough where we have treatments already approved, and treatments always help us categorize diseases, especially when we treat them. I'll give you examples, including HER2 new positive breast cancer. This is really a function of a therapy. Biology is a little bit different, true, but it's really a therapeutic designation. Microsatellite instability tumors, or MSSI tumors, is another way we define diseases by therapies. And infections are also often defined by the treatments that are approved, like, for example, vancomycin-resistant enterococcus. So because we don't have a lot of therapies approved, I think it also makes it difficult to really categorize our cancer cachexia. The other issue is how do you conceptualize the target population? So if you're developing a cachexia trial for cancer patients and you want to include pancreas cancer, are you coming from a framework where cancer cachexia is a subcategorization of cachexia and pancreatic cancer is a subcategory of cancer cachexia? Or are you conceptualizing it like I often do, that we have a pancreas cancer population with the majority having cachexia? And that would change your inclusion criteria, would change how you approach the clinical trial in a way. So this is definitely something interesting. And you'll see clinical trials that kind of have, one approach or the other. They'll take one or the other, which is interesting. The other issue is trial endpoints. Endpoints are probably one of the most important components of a clinical trial. And we have tons of endpoints that we use for cancer therapeutics that we know are reproducible, that work, that get us to the, what we need to do, can get us, if we have this endpoint and we show a significant difference, that it's meaningful and that we can get this medication approved. In cachexia, it's a little bit more difficult. So, if your objective is changes in body composition, yes, we have endpoints in lean body mass, but improvements in lean body mass is not yet recognized as enough to get a therapy approved, right? What if your objective is to look at, protein and energy balance, secondary to food intake of normal metabolism? Well, those endpoints could include weight loss or anorexia measures, and there's several anorexia measures. So there are ways, I think there are anorexic drugs that can be approved using anorexia scales. We'll see an example of that. And then finally, changes in functional impairment. This is really tough because we haven't really been able to develop an endpoint where it's reproducible enough to get a therapy approved. And, of course, we're all working on this very hard. And I think one of the newest measures in functional change is actigraphy, which we'll talk about soon. So these endpoints in cachexia are difficult. They're tough. And my biggest issue is I don't have a good trial that I can copy yet. Maybe soon we will. I think we will soon have a positive trial that we can use as kind of, a framework to help us as we move along. So I think that's the last issue. And then now I would like to just go over all the different trials that are in pancreas cancer, cachexia, just to kind of go through them and educate the group on those. Okay, the first one is the MENAC trial. Is anyone here familiar or involved in the MENAC trial on this call? Okay, so Let me see on the chat. Okay. Yes, Dr. Garcia, good. Okay, so this is a multimodal intervention of nutrition, anti-inflammatory medication, plus standard of care for cachexia patients. It includes nutritional supplements and advice. We use ProSure and EPA supplements. There's also a home-based, self-assisted exercise program and anti-inflammatory medication. And we are using ibuprofen. So the inclusion criteria. This includes either non-small cell lung cancer or pancreatic adenocarcinoma, who are about to start the first or second line cancer therapy. So here's an approach where the cachexia therapy is kind of folded into the standard chemotherapeutics, which I think is a great approach. This trial does include two groups of patients, lung and pancreas. And then, of course, there's staging, which is really standard of care staging. There's some issues of Karnofsky performance status. There's exclusion criteria, like we talked about. Neuroendocrine tumors are different tumors, so that's really important. You need to get the right biology. You need to be treating the right type of tumor. It's really important. And I think maybe lung cancers might need to be further classified. I mean, there might be differences in weight. I'm not too familiar with the literature in lung cancer, whether KRAS alterations affect those issues, but that might be an issue in lung cancer because therapies are really quite different depending on the cancer type. Other exclusion criteria for the MENAC trial is patients receiving enteroparenteral nutrition, patients who are overweight, and use of other stimulants for appetite. So there are 17 centers participating. I guess it's almost half and half between Europe and North America. This is, I have to say, compared to most pharmaceutical sponsored trials, a smaller number of sites participating, but the accrual has been very good. Several hundred patients are going to be enrolled, and the trial is coming up to closure. I think there's been some issues with accrual during COVID, which is understandable, but things have been improving recently. So here's what the MENAC trial looks like as far as the intervention. So patients present to the clinic, they're enrolled in the trial. So a patient will present with pancreas cancer, for example. They'll have weight loss. We'll talk to them about their standard treatment, and then I will introduce this concept to them of, hey, you have a lot of weight loss. There's this intervention that can address your weight loss and improve your outcomes. Is this something you're interested in? Almost every patient has said yes. They're very, very interested and excited to participate. Not everyone gets the intervention. It's a randomized trial, but at 6 weeks, patients do cross over, which makes this trial incredibly patient-friendly. So from that point, it's been a huge success. I think this could serve as a template for future trials. Now, the study endpoints, the primary endpoint is body weight, and that's the difference between intervention and control. And I think that's a great endpoint for this patient population. And hopefully we'll see how effective this endpoint is at the end of it. Secondary outcomes include measuring muscle mass and physical activity as assessed by an active PAL device. Other exploratory objectives include the timed up and go test, the Karnofsky performance score, food intake through surveys, quality of life through the ERTC, which is great, and the QLQ CAX 24. All right, so the next trial I'm going to talk about. Okay, so there's a question. Are there any alterations? Okay, so here's a great question. Someone asking a question about pancreas cancer, cachexia. Is there alteration in liver function in the patients? ALT, AST levels? Grant Hatch is asking because he saw liver metabolism upregulated in rats. That's a great question. We do see things such as fatty liver and other environmental changes in liver, but not necessarily a change in liver function. but that's an excellent question. So we don't have a lot of liver tissue on these patients who have pancreas cancer, unfortunately. We do get liver tissue sometimes when we biopsy the tumor. And then when we do that, we'll get some liver parenchyma. And then there'll be, if there are changes in the liver, we don't know whether to attribute it to, okay, this patient might be a little overweight. Oh, this patient had chemo damages the liver. All the hepatologists love to tell me how much my chemo damages the liver. So we'll never really get a good handle on what's going on in the liver. But that's an excellent question. I also think it's really important to understand that patients who have pancreas cancer, I mean, the number one site of metastasis is the liver. And we don't really understand why that is. It almost always goes to the liver. And if you have a patient who metastasized to the lung versus the liver, it's almost like a different cancer. They do much better. It's almost like a different, I don't know why. It's something special and unique. We're trying to understand that. So I think there is something going on. There is some kind of relationship that I don't understand. And I think that a lot of groups are working on. There's a PL1 in our institution looking at why some patients are more likely to develop liver mets than others, and whether or not there are changes in the background liver that predispose tumors to be able to grow there. So I think it's an important question. And that might be the same for weight loss. We do see, interesting. Okay, so let's look at the next trial. This is the one, Rishi just got his poster accepted at ESMO. Congratulations, it's a great conference. He was a little bit disappointed it was an oral presentation, but my God, that's a it's a preliminary results that are getting published. So congrats, Rishi, that's great. So let's talk about this GD15 and T-FROL. So there's a novel molecule that targets growth differentiated factor 15, which is a circulating member of dimeric proteins. So this antagonist is very exclusive to the receptor for GFROL, and it's been shown in preclinical studies to really improve weight loss and outcomes in cancer models. So it's a first-in-class molecule that is being developed as not only a cachexia agent, but also to help ameliorate the effects of tumors and actually control tumor growth by resetting the catabolic anabolic balance and also relieving GDF15 mediated immune suppression. Okay, so this makes it an interesting molecule in that it's kind of being developed in two different ways. So in this trial, it's being done as a single agent in addition to chemotherapy. So the phase 1 portion was completed. Rishi, did you see any toxicity in the phase 1A part?
No, I don't think any significant toxicity signals were attributed to NGM. Seems pretty.
This is my favorite part of this molecule. It's really very few side effects. So that's always very good, especially if you're doing a study on cachexia, because if your drug is causing, nausea and vomiting and other issues, it's harder to meet your endpoints. So yeah, that's one really, really nice thing about this molecule. So right now we're in the randomized, we had a single arm portion where it was added to the standard chemotherapy, and now it's being expanded in that patient population and randomized. So it's being randomized between chemotherapy plus this molecule versus chemotherapy alone and placebo, I guess. And the objective, so this is where it gets interesting. So the phase 1 portion, all phase 1 trials are always safety and tolerability. And then the second portion is really looking for an early signal. And there's two types of signals we're going to be looking at. There's an improvement in outcomes, which is usually for cancer, it's either progression-free survival, which means the time it takes for the tumor to grow, or overall survival. And on the cachexia side, it's going to be looking at weight and lean body mass changes. And also in this trial, we see actigraphy. So it's another theme. So actigraphy is making its way into almost all these trials for cancer cachexia, which I find very interesting, because you won't see actigraphy in any other type of clinical trial, I don't think, that I know of. Maybe I could be corrected. I'm looking for the chat to see if anyone's going to correct me. I don't see any. Okay. So this is a great trial. This is a trial that I think was designed remember we talked about conceptualizing these cachexia within the particular cancer. So this is very much almost like a pancreas cancer trial, and you're adding a few endpoints for cachexia, hoping that a cachexia agent will improve the outcomes that you normally would use for cancer care. So I think this is a great approach, and fingers crossed that this works out. So the inclusion, exclusion, in the phase 1 portion, they take almost any tumor, but now in this expansion cohort, we call it, it's only pancreas cancer. And the criteria is a little bit strict as far as you have to be first line, they can't have received prior treatment. These are very similar to the criteria we would use for any kind of pancreas cancer trial. And you notice what's really interesting is we don't even include baseline weight loss. We just assume that cachexia is part of the disease, which I think is a good assumption and something that we should probably do going forward. Of course, we have to see how this trial works out, but I think it could be a very nice way of not selecting patients who are necessarily very poor prognostic, taking our worst prognosis patients and putting them on trials and hoping that we can somehow overcome that. Okay, so this is what I find so interesting about this molecule and how we talked about different ways of approaching drug approvals. So here's the same molecule. This is from Pfizer. Now, Pfizer has 2 trials that are ongoing. One of them is structured similarly to the previous trial, which is in addition to chemo as kind of an anti-cancer combination therapy. Here we have a kind of a different framework where we take cancer patients who have anorexia and we treat them with this drug. So this is really an anorexia trial in patients who have cancer, not an addition to chemo trial, not complementing therapy that's already ongoing. So this is a 6-week double-blind study to compare this new medication versus placebo. So same molecule, completely different approach, which I think we're in a very, very fortunate to have these two, and we can actually see how these trials develop. So I'm really excited about that. So here, the primary outcome is the effect on this molecule on appetite, and this is going to be assessed patient-reported symptom assessment appetite scale. Secondary outcomes include a 7-day recall on cachexia symptom score. Third. Also looking at associated fatigue and a 7-day recall. Of course, incident of adverse events and looking at laboratory abnormalities, which is always done in these types of trials. Okay, so again, I think very interesting that we have the same molecule being designed in 2 different ways. And again, I'm really excited to see the results of both of those trials. Okay, and finally, we have a different way of incorporating cachexia research into clinical trial development. So I wanted to share with you this Precision Promise. So this is a new consortium trial for pancreatic cancer. It's based on the fact that this came out of a need that was recognized, that there's so many negative pancreas cancer trials from the therapeutic end that it's become very discouraging and very difficult to continue to open and close these trials. And the thought was that if we have a platform adaptive trial, we could do this in a lot more efficient way. So this group started almost 5 years ago. It took a long time to finally develop this platform as how we were going to do it. I mean, we knew we needed to get together to change the way research was done, but how it was going to happen, it took a lot of false starts before we got it right. So adaptive usually means that the statisticians developed a way that certain arms in the trial will be favored, and the trial will change as time goes on to reflect the results of the trial. So the trial evolves with time. So you never open and close a trial with one objective, with one drug. The whole system is adaptive and organic. And platform means that multiple drugs can be tested at the same time. And you can utilize one control arm for several different arms, which increases your efficiency considerably. This trial is a registration trial. So it's already been discussed with the FDA. And if it meets its endpoints, it will be on track for registration, which is very exciting. And this is what it kind of looks like. For probably most of the people here, this looks like doesn't make any sense. But so a patient will come in, they'll see the doctor, they'll have a consent form, they'll get screening, they'll look at their eligibility, they get randomized to any one of several arms. And again, there's control arms as well as experimental arms. And in this trial, what's also really neat is that after first line, they get re-randomized and go back into the trial again for second line. So it's really exciting design. And what we've been able to do in this trial is also to include molecular testing and biomarker exploration of all patients. Tissue and blood will be collected, fresh tissue. We'll have uniform molecular testing at baseline in 8 weeks. And all this tissue and blood are collected for future research. So if any scientists here who want to piggyback off this platform to study cancer cachexia, this is one of the reasons why this trial was designed, just for that. There's patient-reported outcomes that we are collecting. So we're actually asking patients to report on their quality of life, performance, their anorexic cachexia scales, and very specifically patient-reported adverse events and toxicity, because we were wanting to see how much the therapy will affect some of our cachexia endpoints, right? There's always this question of does cancer therapy really play a big role in weight loss and cachexia? And we're going to be able to answer that question a little bit better going forward in this randomized prospective trial. There's also an actigraphy sub-study that is optional for patients to participate in. So patients, as they go through their standard treatment or their experimental arms, will be using actigraphy devices. We're using Fitbit in this trial. Body composition analysis will also be done in this trial. Vicky is part of our supportive care group, and she'll be helping to conduct that. So we will have serial scans that are used to assess response to treatment, but will also be used for quantification of muscle and fat loss. Okay, and this is more of the stage 1 and stage 2, which I don't think is relevant to the conversation today, but basically it's a phase 2-3 designed together. So the phase 2 portion is, and it's really efficient because basically you have to size, because you're kind of using the same patients for the phase 2 that for the phase 3. So you're kind of folding in the phase 2 within the phase 3. But after a certain number of patients in phase 2, you do a statistical analysis to make sure that it makes statistical sense to proceed to the phase 3 part. So a lot of the trials will end early, which is good. I mean, if an intervention is not working, that will fall off. All right. Again, we talked about the molecular profiling and the research samples that are being collected for future research. And we have a supportive care arm or appendix where we really try to push the envelope and really try to understand the best supportive care practices for this cancer. A lot of that has to do with weight loss. We also recently have a grant that was supplied from AbbVie for us to be able to provide all patients on the clinical trial of pancreatic enzymes. So that's part of the trial as well. We talked about these. And some of the PROs that will be include Promise 29, some adverse events from the patient side. And we talked about these. The brief fatigue inventory and the FACET will also be used. So I don't know if there's any differences between the Active Pal or Fitbit that's important, any distinctions there. I think the Active Pal is nice because it's kind of stuck on to the body and patients can't take it off. And the Fitbits, patients will take that off. I mean, we tell them not to, but they'll take it off invariably to charge it, or sometimes they don't really like it. I had a patient this morning who said, "Oh, I've never worn a watch in my life, and now I've been wearing this Fitbit for 1 month. Do I really need to keep wearing it?" So it's a little bit of a different type of actigraphy, but I think we'll see how much data loss we have. I think that's one question in using Fitbits versus other types of actigraphy. I know there are groups also looking at whether or not to include actigraphy into instruments such as portacaths or the chemotherapy devices that could, mitigate that issue. Or maybe using the smartphone instead of a where they're getting the same issue, smartphone being on them all day. Yeah. Also, we talked about body composition analysis. So that's very, I think, useful for our type of research to answer questions that we might have. This is the consortium. So it's a nice combination of academia, industry. Trial sites are growing. We're going up to 20, and there'll be additional sites added. So if there are any sites out there that think that this is a trial that they would want to participate in, definitely reach out and see if you can get in the mix. And yeah, so I just wanted to end this with just saying, Cachexia trial design, it's an exciting time. It's evolving. And, thanks for joining me on this discussion today. So available for any questions or comments.
Thanks so much, Andrew, for that great talk and covering some of the exciting trials that are going on. I think one thing that I don't know if you mentioned, in the NGM trial, at least, there is a requirement to have a certain GDF-15 level as an inclusion criteria. So, my understanding is that level was pretty generous and that most patients should meet that threshold. And I think out of the patients we've screened, only one didn't meet that threshold. So, but I think that is exciting that it is kind of, a little more precise in terms of the biomarker selection for the patient. So, but thanks so much for that overview.
Yeah.
Do you want to? Oh, sorry. Go ahead.
Yeah, for GDF-15. So there was a lot of work done before the trial started, looking at different cancer types that had elevated levels of GDF-15 circulating, and pancreas cancer was found to be one of the most enriched tumors for that, and that's why pancreas cancer became the target disease. Yeah, that's a great point. So there is a biomarker, and that's another distinction between that trial and the Pfizer trial, right? Which there is no biomarker for the anorexia, which kind of makes sense when you're thinking about the trials in different conceptual frameworks, right? One is more of a therapeutic trial, and one is more of an anorexia trial. Yeah.
I think Sham, do you have a question?
Yes, I have a question that cancer can induce liver cachexia as well as kidney cachexia and brain cachexia. Are those studies included in the clinical trial?
I think, we are including patient self-report of fatigue and other, issues that have to do with cognition and depression and things like that. Outside of that, is there a way that you would recommend we assess it? We do assess liver function and kidney function. But as far as, other ways that cachexia affects those organs, I'm not sure how we would do that.
I have one announcement to make, which I can make later if somebody has a question. I've been invited to serve as a guest editor for cancer-induced cachexia, which I selected topic by cells, and impact factor for cells came for this year is 6.6. So it's very attractive. So I sent on the chat, I wrote a message, and then my email is there. So I invite other people to submit the article, related research article, our review article, our clinical trial information, our short communication. We want to make this one really, I know it's understudied area, and we don't have any specific drug except the one you have discussed in the trial. But I want to upgrade this field, cancer-induced cachexia, so that we all can be benefited. So we want some good articles for this specific issue. So my email is there. So anybody interested, please contact me. We can send the instruction and other information. I appreciate few articles coming from the society members.
You got it, Dr. Kakar. Thank you.
So I think we have some more questions. Dr. Kumar, I think you have your hand raised.
Yes, thank you for that great overview. I have some concerns about this whole area because I've been a nutritionist for quite a long time, and I'm also a cancer researcher. But number one, it's still unclear what the etiology of cancer cachexia is. And unless that is well characterized, and we know it's a multifactorial disease with a major inflammatory component to it. So all the work that's being done currently doesn't really target some of the etiological components of cancer cachexia. That has been our challenge. And I don't think we're any further than we were before. I also wonder why we are not adapting a more aggressive approach in biomarker identification. Because again, unless we know the etiology of the disease, the molecular basis, or even the inflammatory basis of it, I don't see any inflammatory markers, biomarkers in any of the clinical trials that are ongoing. I understand that's a challenge, and that has been a challenge to our team here at Moffitt also. And I want someone to comment about it. And also some of the target populations that have been selected, we have if these protocols go into an NCI review, it will get, massacred because the heterogeneity of the cohorts is like so varied. So what are we going to learn from these trials? I don't know. I mean, I'm very
So I think that the understanding that cancer cachexia is inflammatory, I think is works in preclinical models probably better in the clinical models. There are a lot of markers for inflammation that are always checked in these diseases, and have been, I guess I've seen lots of cohorts looking at patients with weight loss in cancer, looking at inflammatory markers. Nothing really stands out as a good predictive biomarker that could be used to select patients for therapy. And all the anti-inflammatory therapies that have been tried so far have not yielded results. So I know the MANAC trial is really pushing, ibuprofen and NSAID use in this patient group. And I'm praying, I think it helps a lot. And I think you're right. But other, novel anti-inflammatory therapeutics have not really moved the dial in the disease. So whether it's when we're checking the wrong things or there is a Glasgow performance score in pancreas cancer, which looks at CRP and albumin, both markers of inflammation, and these patients definitely do worse. But when we use anti-inflammatories in therapy trials, they don't really work too much. They don't really work too well. And I get what you're saying about the NCI and clinical trials. Industry trials are a little bit different, and therapeutic trials are a little bit different. So not a lot of NCI trials end up approving drugs. So the goals are usually a little bit different. So the way I would compare it is, you're right, the NCI trials are probably more rigorous in establishing principles, and most therapeutic trials are really more focused on the results rather than why. So I think you bring up great points. These are really huge issues. Again, if anybody wants to interrogate the current databases that are being collected to try to find novel biomarkers, there's so many researchers such as yourself that are looking into it. It's huge. And we definitely should work together more to try to figure out the best way forward.
Thank you, Andrew. I didn't want to be too negative, but
you have
definitely these are challenges that we face, and also as a reviewer of the special emphasis panels and things like that. So we come across trials that are not tight and are not rigorous and don't get approved or don't even pass the litmus test there. But the other point I wanted to also make is, we all experienced the odds effect of COVID-19. And we saw cachexia, acute cachexia in those patients in a subgroup of them. And why don't we adapt some of the biomarkers that they look at there? Ferritin is a great biomarker, of protein loss or muscle loss.
Which
We
one?
never use it. Ferritin, serum
Oh,
ferritin.
ferritin, sure. Yeah.
And we don't use that in cachexia. So there are several inflammatory markers that were used in COVID that has never been used in cachexia. These are things that are adaptable. And even when you talked about anti-inflammatory agents, we've never been aggressive about it. At the most, we're using ibuprofen. We're not even using NSAID like diclofenac or
Right.
something a little more
Right.
powerful than ibuprofen. So I think we haven't gone there yet, and I really challenge this group to take it to another level.
Well,
Because there are so many clinicians in this group, I see.
well, I'm glad we're having this conversation. I think maybe one of the issues is that maybe the scientists and the clinicians aren't talking enough. Recently we were approached by a company, pharmaceutical partner that wants to develop diclofenac or ketocorrelac, a ketocorrelac type drug for cancer cachexia because of their preclinical data. So maybe that's something that we can discuss with you on what kind of markers to look at and what kind of data to collect during the intervention, early phase intervention.
Thank you.
Yeah, it's great. You bring great points. You're absolutely right.
That was a great discussion and a big challenge ahead of us. Fabio, did you have a question? I saw your hand raised. If not, then
Yeah, Dennis
yes,
had
I was trying to open the mic. Can I?
Yeah, go ahead. We can hear you.
Sorry, I'm a basic scientist, so sorry for the naive question. But I was interested in when you mentioned the smartwatches, so for measuring the physical activity. Just a few years ago, those very cheap instruments were not available. And if we look at the monitoring cachexia, there were tests that were set up like the SPPB, the 6-minute walk test, and so on. I think those are pretty stressful. I do have collaborators here in Italy trying to do them, but the adherence, the patients are not that happy when they enter the hospital to do those tests. I think that wearing a watch is less stressful. What is your opinion on that? And what is the value? I think if we can monitor patient activity for 1 week or 1 month, as a value that is much higher than measuring in one single session what the patient can do, that can be prone to errors. Even many are using just the grip strength that for me has no value at all. But I would like to know the opinion from the people really working with patients. What is your?
Yeah, I completely agree with you, Fabio. I think that some of the advantages of the Fitbit are not only that you have continuous measurements, that it is patient friendly unless the patients don't wear it, and you do get a good idea of what's going on daily and how that relates to other factors that may or may not be present on the day of your evaluation. The other thing that's really interesting about these devices is they measure heart rate and they also measure sleep. So you do get additional data as well, which could also be eye-opening and interesting in our field. Whether it's not validated as well as the other tests, I think that's the problem.
Yeah.
And we need people to validate them. And I'm not the one. I don't know enough to do it. So I'll open it up to the rest of the panel. Does anyone have any other thoughts? I mean, I guess we just really need to get this actigraphy, validated and accepted as a functional endpoint.
Yeah, maybe even for the assessment of cachexia, when you're physically inactive, and when you think at treatment, it makes a huge difference as compared to when you have in front an individual that is willing to be active, that is active, and on that patient you can give treatments that are likely to be more effective rather than in a patient that will be completely inactive. Just my opinion. That's what I see with mice, but I don't work with humans.
I think you're right. Absolutely right.
Okay. Thank you very much again.
Yeah, thank you, Fabio. Anyone else have any thoughts on that topic?
No, the patients on the NGM study that are wearing the Fitbits have found it somewhat useful to kind of self-assess how they're doing and kind of remind themselves to be physically active. And, so I think there could be a behavioral component to it too, where it could kind of motivate people to meet, different goals or surpass their prior goals. But I agree, they're relatively new in the oncology space and need some more data. We have a few more minutes. I think Dennis asked a really good question. So his question is, for future cachexia trials in pancreas cancer, when will we start seeing the treatment for cachexia starting in earlier stage patients? Because most of the emphasis to date has been in patients with metastatic disease, but I do think there's data that cachexia can be present in the earlier stages as well. So any thoughts on that?
Yeah, I think that's a great point and something that has to be considered. I think that's why maybe, taking out, when you have a disease such as PDAC, where almost all the patients are cachectic, whether at presentation or through the course of the disease, it almost makes sense to not include language regarding cachexia specifically and just have the diagnosis of PDAC. And again, another thing that can be helpful is to do it earlier. All therapies work better the earlier you give them, any type of therapy that you can pick. So anytime you do an intervention earlier in the disease course, you'll have a better litmus test for its effectiveness. So yeah, I think it's a great point that Dennis brings up, and something that's you can see it in our trials that we discussed today. A lot of them are first line trials, so that's great.
There's a question that Erin sent to me. Her question is, do you think that the treatments that we've discussed for cachexia in pancreas cancer and lung cancer are going to translate to the same effectiveness in other types of cancers? Or do we think that different diseases with cachexia would have to be treated differently?
That's a great question. I don't want to say, I feel like I'll be stepping out of line if I tell you what I think. I mean, there are a lot of people that have been doing in this field a lot longer. I'm biased towards disease specific approaches. But what do I know? So, I kind of think that maybe it makes sense to do. I do think that maybe not necessarily disease specific, but some diseases will require like a biomarker or a target population. So in my mind, I think pancreas cancer is a very homogeneous cancer as far as, biologically and what it does to people. But other cancers are not. It's like lung cancer is quite heterogeneous. So in my mind, I think that there could be a subgroup of lung cancer that's similar to pancreas, and maybe that's KRAS mutated, but maybe not all lung. You know what I mean? So there's got to be, in different diseases, I think do need to be approached differently. Whether the therapies have to be different, I'm not too sure, but definitely maybe patient selection, biomarker development has to be more rigorous to make sure that you're not, I know in colon cancer, a lot of the clinical trials have been hampered by, it's not a disease that is characterized by all patients by cachexia. So, it's one of those things where you have to be careful about who you include, and patient selection probably plays a big role.
Thanks. Any other questions? If not, I just wanted to ask you one thing. So maybe while we see if any more questions trickle in, you showed your algorithm on how you guys approach, or how we should approach the assessment and workup and interventions for patients with pancreas cancer. I'm just curious, at Cedars-Sinai, do you how does it work when a patient comes in with pancreas cancer? Like, is there a dietitian in your clinic that is always there to see the patient? And how does the physical therapy referral work? Just kind of the workflow of it, just because that's sometimes challenging for us. Sometimes if I put in a referral for a dietitian, they give an appointment a month later, and then unfortunately people continue to lose weight for a few weeks before they're seen. So I just wanted to kind of hear how you're implementing that algorithm at Sinai.
So that's a great point, Rishi. I think the issue for the clinical management of cachexia is that you really need to bring in the dietitian and the physical therapist as part of your treatment team right from the beginning. So instead of them being an ancillary service, they're really one of the team members, and that includes also supportive care. So we really, when I first see a patient, they will get all these specialties will know that they'll, be seeing these patients. Now, you also have to get buy-in from the practitioners, right? So you have to have a dietitian. You might have to educate them. You might have to include them in your research. Same with physical therapy. I think it's really important. You're leading the field. You're trying to understand this. You have to bring those team members into the process, and they'll work with you, because normally, this is not something that they normally do, right? Physical therapists will say, why do you keep sending me all your pancreas cancer patients? What's wrong with you? And I say, well, they're lost weight, they're cachexia, you need to build them back up. And then they're like, okay, so let's put a protocol together. Let's do research. And the same with our dietitian. Our dietitian's involved in our research. So that's the way of getting the team together. But you're right, it's very difficult in routine care to get that kind of support. It really is.
Yeah, I mean, everyone's busy and there's space constraints in our clinic. So there's a variety of barriers.
Yeah. Cachexia is a tough illness. It's the hardest one, right? These are patients, especially cancer cachexia, right? They're sick, they're advanced, they're not doing well. It's not everyone's, they don't wake up saying, I hope I see a bunch of cancer cachexia today. Therapists aren't thinking that, and neither do dietitians. It's challenging. But if you get them involved as more of a team, and that expectation starts to develop, I think that's the way to do it. And I think most of the cachexia centers where they have specialists kind of take that team-based approach, where there are just several components, everybody working at the same time.
Yeah. So if there's no further questions, we'll wrap up. Thank you so much.
Thanks for having me, guys.
It was a pleasure. And we look forward to seeing everyone at the conference in August. So
Forward to it.
Take care, everyone.